Right, good afternoon everyone, and welcome to second webinar this week, our third in a series looking at optimizing timely discharge. It's great to see some familiar faces in the on the call so far, so welcome back, and it gives me great pleasure to introduce our expert panel who will be joining us for the discussion today. So if I could just introduce people and get them to wave their hands. We've got Lynn Quinney from the Patient and Carer Network. Lovely to see you, Lynn. Thank you very much. We've got Wendy Rees as a colleague from ESIS and nurse representative. And we've got my colleague Dan Smith, who is the most senior junior doctor possibly in the UK. And all of us have been working together on the Modern Ward Rounds Collaborative. So I spent a lot of time virtually. Dan and I have actually met once, I think, in our time together in ESIS, which is a sort of telling thing. So before we start, Crystal on the call will be helping with some technical support and also be running the slides. The aim of the webinar today is I'm just going to run through a few slides, and then we're going to invite sort of conversations with members of the MDT, looking specifically at once the decision to discharge a patient has been made, how as an MDT can we facilitate that in the most timely way. And I'll bring people in. Please do share experiences, pass comment, and use the chat function. We'll be monitoring it throughout the webinar. If we can start the slides, if that's okay, Crystal, thank you very much. So just to highlight a couple of the objectives, you can read there, but the idea is to raise awareness of the various tasks and processes as an MDT rather than in our professional silos. We're going to highlight some of the various tools and aids that are available. And just to say at the end of today's webinar, there will be a handout. We'll put the handout in the chat room, but we'll also email everyone who's attended at the end. And the idea of today's webinar is to facilitate discussion and share best practice. Next slide, please, Crystal. So I just thought, as I did on Tuesday, and hopefully a little bit more eloquently than I did on Tuesday, I'd like to just set the scene for us all. And I know that we've got a combination of clinical and operational leaders joining us today. The reason for putting these webinars on is a recognition of the incredible challenges we are facing at the moment, and there are a number of factors to this. The key thing for me personally is around the workforce, both in hospital and out of hospital for healthcare and social care. And one of the challenges for timely discharge and ward-based working in particular is a real challenge to continuity of care with different members of staff on different wards, different locations at different times. So it's a really challenging environment, I think. This is balanced against a real performance drive from the centre, which I'm sure many of you will be feeling much more acutely than people like myself. And this comes at a time when there's unprecedented demand for UEC services, as well as driving the elective recovery programme. And then there's also the societal context that I think is important to highlight, where we have people who are fearful of going into residential and nursing care for their loved ones and relatives. We've got challenges around people trying to earn a living and getting timely access. So it's a really hostile environment in which to sort of optimize and deliver the best care that we'd like to. I'd just like to say, though, in that context, I'm on site at Ipswich at the moment. I've been privileged to work with the team here in my ESIS capacity and seen some wonderful care. And I know that there's wonderful care going up and down across the country at the moment. And so it's a real credit to all of the clinical teams and the operational teams for the way they're behaving and performing in these difficult times. Next slide, please, Crystal. So on Tuesday, Anne-Louise Schocker, one of our clinical associates and a consultant geriatrician at United Hospitals Lincolnshire, and one of the associate medical directors there, gave a presentation on the work that she's been leading in her own organisation around the clinical leadership that's and why that's important for decision making around timely discharge. And I thought it was worthwhile, just for those who weren't able to join the call on Tuesday, just to highlight Anne-Louise's sort of top tip stroke mantra when she as a clinical leader is reviewing patients. So her questions there, you can read them through for yourself, and I won't go over them today. However, we're going to focus on the decision making once not the decision making, but the processes and the tasks that need to happen once the clinical decision for a patient to be discharged has been made. So next slide, please. We're going to focus on 3/4 aspects. I say 3 because the middle 2 around clinical engagement and clinical ownership, I think, is very much wrapped up in the clinical working from the professional groups within the MDT. We're delighted to be joined by Lynn, who's going to highlight the importance of patient engagement in this process. We also wanted to highlight some of the organisational processes around this. So next slide, please. We are going to make today's webinar interactive, and I make no apologies for that. So we just, as a bit of a if you like, a Menti icebreaker, if you just scan the QR code now, or if you go to menti.com or on your devices with the code 52495267. That's 52495267. We're going to switch over there, and it's going to ask you one question, which is, what are the 3 top reasons why people are delayed from leaving your wards today? I'll just give a couple of minutes and see how that runs. I don't know if there's a slight delay or everyone's just a bit shy. Oh, here we go. Bit of a Wi-Fi lag. Okay, so a lot coming through at the moment around the more complicated discharges, but interesting around late diagnostic tests. Something around communication, which we'll cover on later. Crystal, I don't know whether the slides will scroll down.
Yeah, so it should do it automatically, in theory.
Thank you.
Yeah. I think that's it for the moment.
Okay, thank you very much, Crystal. So I guess I'm not surprised by the responses we've got so far, and certainly when you're on the wards and working on the wards and looking at other people's practices and things, the more complicated patients on pathways 1, 2 and 3, those who need a package of care, for example, there often are the high profile patients rather, when it comes to delays. One of the key things though for us to reflect on our conversation today are those patients who perhaps arguably we have more control over, in terms of when they're discharged, how they're discharged, and how much influence we as an MDT play in that. So next slide, please. So, and could I ask just everyone to go on mute if you're not talking? That's great. Thank you very much. So, because we've got a number of clinical leaders and operational leaders on the call, I just thought I'd put this slide in to put a bit of challenge out there around how good the organisational processes are for optimising timely discharge once a decision to discharge has been made. So, and I'll give you some examples as we go through. So in my own organisation, we did some work on pharmacy prescribing and TTAs and things, and it turns out that it's the same pharmacists that do medicines reconciliation on the wards in the morning who then dispense the TTAs in the afternoon. So actually there's an obvious demand and capacity mismatch within pharmacy in terms of getting timely TTAs or TTOs to facilitate early discharge. So that's just one example. There will be other examples around your therapist. So somewhere else I've worked, we've had to compromise on the time of our board round because the therapist was shared between our ward and ITU. So we had to compromise on making some of the decisions as an MDT around that. The second thing is around IT systems. Most of us use IT systems and they can be fantastically effective, but equally very frustrating if you don't have enough, for example, workstations for all the MDT members to access at the same time. So if people are not able to run electronic recording and documentation in parallel, then there are natural delays with that. One of the key things that we want to explore today is around a directory of services. We on this call, I suspect, are pretty familiar with a lot of the services that are available in the community, alternative models of care or provisions of care, I should say. But how many of our junior doctors, how many of our Band 5 nurses, Band 5, 6 therapists on the ward are aware of those directory of services? And I'll give you an example that came up in one of our clinical associate calls recently. So if you go into urinary retention on a medical ward, you'll often end up catheterized and wait for a urology referral for 3 days. If you present to the emergency department in the same hospital with urinary retention, there's a very clear-cut pathway for patients who are catheterized, discharged and plugged straight into the trial without catheter clinic. So it's just highlighting the discrepancies in some of these services for patients if they're on the ward or if they're not, and spreading the knowledge of what's out there. The other thing I wanted to highlight, because we in ESIST often get tarnished with a similar brush for those people on the wards in more people on the call and more operational roles. This is really tricky, but we're looking at the criteria to reside, how many patients meet the criteria to reside, what we're going to do about it, why is the dial not being turned, all that kind of negative connotation, where actually we forget that most people are discharged from hospital on pathway 0 in an uncomplicated way, and lots of wards are doing fantastic work in discharging the simple discharges as well as they can in difficult systems. So one of the things that I'd urge everyone to reflect on is making sure that you are kind and compassionate to your ward teams, not only about the more tricky patients, but also how well they are doing, if indeed they are, around the less complicated patients. And the last point is around the path of least resistance. So as human beings, we will always go down the path of least resistance. And we'll see that frequently in hospital processes around over-prescribing therapy care, for example. And I've got another slide in a second that I want to explore with you, just around the use of a discharge lounge. So I'm going to explore how many of us on the call have a discharge lounge, how effectively it is used, and just to highlight the fact that actually, if you had a discharge lounge and it was being utilised effectively, it would speed up the discharge of the uncomplicated patient from your ward and help decongest EDs, which we know about. So, Crystal, can we move on to the next Menti, if that's okay? So as we did before, so scan the QR code if you haven't already, or enter the code 52495267, and I think we've got a series of 3 questions lined up for you. There'll be a slight delay while we change the screens over to the Menti. Thank you, Crystal. First reflection for me, we should have set this up as a bar graph. I was hoping to come up with a percentage, and now the take-home message is everyone knows that Croydon does. And thank you for people's honesty. So although not used effectively, and we'll explore that, but you can see that some organisations that don't. I also suspect that there will be levels of levels of access. So, you know, some places will only take ambulant patients, other patients won't take patients on trolleys. We've been to an organisation recently that has a COVID discharge lounge and a non-COVID discharge lounge, all those kind of things. Okay, so can we go to the next question, please? I think we probably already answered some of this. So what percentage of patients use it? So this is really telling, and so my reflection would be just think of the impact that would have on the patients waiting in ED this morning if you had more than 75% of your discharges going through the discharge lounge during the day today. And I know that's easier said than done, but one of the key things is to make it the path of least resistance for the ward-based teams. And I can't remember, forgive my short-term memory loss. Here we are, the language barriers. Thank you very much. Yeah, so there's some interesting comments here around staff confidence, shall we say, or clinical confidence. This is an area we're going to explore shortly. Some comments around provision of TTOs or TTAs. And I know that we've got David Campbell on the call with us today. David, I wasn't sure whether you'd be joining us. So lovely to see you again. Happy New Year. And perhaps we could bring you in the discussion around some of that. Yes, and the narrow criteria, the demand capacity in terms of opening and closing times, all of these things are not uncommon, but from an organisational perspective, they're the things that organisations need to be reflecting on and seeing if you can make timely discharge the path of least resistance for your ward teams. Thank you very much for your comments and openness around that.
Andrew, we've just got
sorry, Crystal.
We've just got one more.
Oh, we got one more, have we? I have got short-term memory loss. Sorry, Crystal. Can you go?
Yeah.
Okay. Thank you. Brilliant. Thank you. And I just everything earlier is the answer, isn't it? I guess one of the questions is, and maybe some people could put this in the chat, have people actually surveyed their ward staff down to the level of sort of junior doctor or band 5 nurse about why they don't use the discharge lounge more frequently? Brilliant, thank you very much. So we'll go back to the main presentation now, if that's okay, Crystal, and we'll try and include the feedback from the mentee in the feedback from the webinar today. So just a slight pause while we switch screens. Obviously that's a royal we. This is Crystal doing all the technology behind the scenes. I can't even count the number of questions on Menti, so don't give me a laptop to use. So what we're going to now do is bring in the MDT. We are also going to be joined by Gary, who's one of our community matron colleagues, but he's currently clinically tied up on the ward, but will join us as soon as he can. So as I say, we've got Lynn, our nurse representative, we've got Wendy, we've got Dan, and we've kindly, if it's okay, David, bring you in. I don't know if you want to unmask yourself and give us a wave. So David again is one of the senior pharmacists who's been working with us on the Modern Ward Round Collaborative. Ah, there he is. Nice to see you, David. Thank you very much. So next slide, please, Crystal. So what we thought when we were putting the webinar together was to try and highlight and facilitate a discussion around the various pieces of the jigsaw from an MDT perspective around what needs to be done, what tasks and processes need to be done, and how to optimize those in order to get patients discharged in a more timely way. And I'm going to start, if I can, with the patient and our patient rep, Lynn. And so one of the things that has come out of the webinars up until this point, Lynn, is that we're still not possibly communicating discharge plans effectively, efficiently with our patients. And I wonder what your thoughts on that and any top tips on how we can improve that.
Okay, thanks, Andrew. I'm conscious that the emphasis today is on the processes once the clinical decision to discharge has been made. But I suppose I'm going to start by saying that I think planning ahead at the very earliest opportunity, well before the clinical decision to discharge has been made, is absolutely critical, and particularly critical not only to the patient but to the patient's family and carers. And I think that early and continuing engagement with not only the patient but those people that they've identified as being important to them, who may be caring for them, etc., is so important here right from the outset. Having that, establishing a relationship with those people, I think, is absolutely critical. So it's about planning ahead, I think. If I can just give you an example from my own experience. My mother, who sadly died last year, in 2016 fell in her care home. It was a small care home, 12 beds, and she was in an upstairs room, and she fell late one evening on her way to the toilet and ended up with a fractured hip. She was admitted to hospital and had efficient and effective surgery to correct the fracture, but she was then in hospital for nearly 4 weeks. Her discharge was a source of great anxiety and concern, because she was in an upstairs room, and the care home didn't have a lift. It had a stair lift only. There was an issue about whether she could actually go back to that room, and there were no downstairs rooms available. And the solutions which the care home manager, unfortunately, I had a very good relationship with the care home manager, and we worked together closely. But the solution that she put forward was for the community physio, who knew the home, to come into the hospital to assess my mother and would then be able to advise. Now, the hospital didn't allow that to happen. So for the patient's family, that was a source of frustration, irritation. Why can't that happen? And I think some of the issues that eventually it was resolved, but it did take longer than my mother was ready for discharge earlier than nearly the 4 weeks time. I think when it comes to discharge, I think patients and carers have sort of perhaps fall into two main camps: people who are desperate to be discharged as soon as possible, and other people who perhaps feel that they're safest in hospital and would like to stay there as long as possible. And I know, again, from working with an improvement team a few years ago, which had a local patient involved, the local patient was very, very sceptical about the plans to improve access and possibly reduce length of stay, because she felt that this was just a big scheme to get rid of the elderly patients as soon as possible. So I think the awareness that the MDT have of the perceptions of the patient and the family is also critical to establishing effective communication with them. That's perhaps those are the main points I want to get across.
And Lynn, thank you, and particularly thank you for sharing your personal experience, which is deeply appreciated. I guess added to that is the current challenge where, you know, visiting is again not permitted in many organisations, and actually communication is done remotely, but not, in my experience, not as efficiently or effectively as it was during COVID times. I don't know whether you've probably seen some really good examples of practice early on in COVID.
Yeah, I mean, I think the use of, you know, iPads and whatever has been a great help. But of course, there are an awful lot of people who do not have access to those. But I think being as creative as possible and establishing what matters to the patient and to the patient's family. I live in Sheffield, where, as people are no doubt aware, there's been a lot of work done on discharge to assess. But that, I think, has been facilitated by the vertical integration of the community care, the community team with the acute trust. But I know there's a lot of concern about how that might work, and a lot of anxiety on the part of carers and families who feel again that it's they're going to be lumbered with people without necessarily knowing the full extent, the full implications. I'm sorry, I've not really answered your question there. I'm conscious of that. I've gone
Lynn, I feel like I'm on the Today programme, which probably shows my age. But I think I guess the point I was trying to highlight is that we have needed to be quite more creative. So I would argue that we've never been great at communicating with relatives and carers. We could always have done better. I think during COVID times that became very explicitly challenging. You know, we couldn't see people face to face, but actually, in my experience, the ward teams worked really hard to work around that with IT or even just phone calls, and you know, mindful of digital exclusion and things. But we're now in a situation where it's less obvious, if you see what I mean. So we're not all donned and doffed, and you know, but we're still restricting access to carers and relatives, and our communication is, as you've highlighted, absolutely fundamental to preparing the patient for discharge and preparing everyone for that. I'm going to, the other thing to highlight, I think, is that there's a really good tool available from NHS England around the 4 questions, which are helpful for staff and for patients. We'll put a link in the chat box, but essentially, when I've done this on wards, when I've been on ward cover, I've been consistently disappointed by the response because of the reflection of my own care and communication. So the 4 questions are: what is wrong with me? What's going to happen to me today? When am I going to go home? And what do I need to do to help myself to get home? And the idea is that in an ideal situation, every patient on every ward will be able to answer all 4 of those questions. And I'm consistently underwhelmed by my own lack of communication when I ask patients those questions and they can't answer them. And so we'll put that up in the chat. It's a really good audit tool for some of your ward staff to undertake, because if we don't get that right, in terms of timely discharge and effective discharge, we're arguably falling at the first hurdle. Hilary in the chat box has highlighted my sort of rather doctor-centric approach to the slides, and others as opposed to social care. And please forgive me, Hilary, it wasn't meant in that light. I don't know, Hilary, whether you want to comment on what Lynn's just said and the role of social care and communication between the healthcare professionals and social care. Sorry to put you on the spot.
Hello, my name is Hilary Pye. I'm a service manager for the Royal Borough of Greenwich, based in an acute hospital. And my discharge team covers 2 acute hospitals. We work very closely with the internal complex discharge team. And again, your comment about communication early on, when we know there's going to be a complex case. Pathways 0, 1 and 2 are fairly straightforward. And there will always be cases that we need to know about from the beginning. The hoarders, the near recourse to public funds, the housing issues. That gives us some time to get involved beforehand. And I put my comment in because often I feel that social care is seen as an add-on, and actually we're as much part of the decision for the complex patients as anything else, especially when you're looking at COPD, some very complex illnesses, which has an effect if they go back to a damp house. And we don't always feel that social care have as an important role as we need to have. Greenwich have been very successful in our discharge to assess process. Particularly around the ADAS, age of intermediate care, what we can provide, which is slipping a bit now because of lack of therapy. But I think that kind of rehab, rehabilitation, even convalescent, to get people out of the acute setting where they shouldn't be making long-term decisions is key. And we can only do that by sharing, really.
Thank you, Hilary.
Each other.
Yeah, thank you. I totally agree with your comments and lots of nods that I can see. I think one of the challenges has, I don't think it was ever done as well as it could have been done, but one of the challenges has been without that face-to-face interaction, that socialization, it's become even more challenging. And I totally agree that, it's the old mantra, isn't it? As the discharge process starts at the point of admission, and so identifying patients as soon as they are admitted to hospital who may need social care needs is absolute paramount. And what I think and that used to be a lot easier with the face-to-face socialization, so you'd meet the social worker even if it wasn't every day, but you'd know someone, you'd have a sort of personal relationship, where when it's remote working or through a hub or whatever, it's all a little bit distant, isn't it? It's not quite as tangible, and therefore people don't perhaps feel as confident as they should, and therefore put it down in the too difficult pile rather than tackling it head on when they start. So thank you for coming in and highlighting a really important point. We've also got Anne from Ashford and St Peters, who's made a comment around risk and being in, and the risk of being in hospital, which I think Lynn articulated very clearly with her own personal experience. We are kind of probably preaching to the converted about that. There are some very good webinars on risk and sharing risk done by some of our colleagues. Ben Owens is an ED physician, and Barath Lakapa is a geriatrician, both of whom working for ESIS, who've presented this work nationally, and it's it's available on our YouTube channel, ESIS YouTube channel, as this webinar will be, and other webinars as well, available in the next couple of days. But Ben and Barath have done a very good webinar on sharing risk and how to articulate that for ward-based staff, so that it becomes meaningful. So I'd encourage you to have a look at that. I think Mark, you make a very valid point, and I think that highlights the challenges with workforce, both in health and social care, in hospital and in the community. And I agree. What I'd like us to do today is really focus on the pathway 0, less complicated patients. I say less complicated, I don't mean that in quite as pejorative way that it sounds, but if you see what I mean, the things that I feel that in hospital are more within our gift to affect their discharge in a more timely manner. So I'm going to pass, in the interest of time now, I'm going to pass over to Wendy and Dan as doctor and nursing representatives on our MDT to discuss the role of documentation, and we talk about criteria-led discharge and those kind of things, and other tools that are available, and we'll highlight in our handout. But actually, criteria-led discharge fundamentally falls down if there's no documentation. So maybe Wendy, if we start with you and then bring Dan in, because obviously Dan's a doctor, so none of us will be able to read his writing. But Wendy, from a nursing perspective, the importance of documentation.
Yeah, absolutely. I mean, documentation is one of the key components of communication, isn't it? And on a busy ward as nurses, I do appreciate that a patient may have been in for some time, but you may actually have just come on shift and you haven't met that patient before. So it's really important that the handover is really concise and really clear about, the sort of reasons why somebody's in, but also what is needed to get them home. I think when the medically that someone's medically well and you're planning for home on that day, I think the most important thing you can do as a nurse is talk to the patient again. As Lynn said, hopefully there's been lots of conversations around, what do you need support with to get home during that person's stay. But on that very day that home has been suggested, then lots of activity around the patient to make sure they're really clear about, they're going home and what the plan is. And Gary I don't think Gary's been able to join us, but Gary has given me some sort of stories that he's come across when he's been working in the community around the fact that what you think patients will worry about sometimes isn't what they're worrying about. So things to do with, equipment that they're not sure about, or they may have a catheter in, or they may have a wound that's new and they're not quite sure what to do about that. So it's just been really, just giving them some advice around how they could self-care and who they need to contact. But things like medication, again, even if their medication hasn't changed significantly, just going through it again with them about, are they able to take it themselves and what times of day, and also being really flexible, so not being too prescriptive with patients around when they have to take medication, because as we know, some people get up really early, some people go to bed really early, so just being really flexible and talking to the patient about what would work for them. But it's that link with community that's really important, and I think it's as nurses on the ward, it's knowing there are really, really good nurses out there as well in the community. Have confidence that if you've made a referral, that your patient will be picked up by that team. If you've got a really urgent need, so you need something the next day, like a blood test, or there's a particular care need that they have the next day, then it's always best to phone and just to give them the heads up. And also, patients often have more information about who's out in the community than we do, because they would probably have accessed lots of services before. And especially people that have had catheters and wounds before, they'll know their district nurses really well, and they may have direct numbers themselves. So you can just say, please do give them a call. But I think things like blood tests, be really clear with the patient, give them the form and give them the power to make that appointment, and give them the understanding of who's going to do their blood. Is it their GP, or is it back in secondary care? Is there an opportunity for you to bring them back into the hospital, into sort of ambulatory care if you're really worried about a particular blood test? So just a few little bits really there around communication and that safety netting around the patient. Over to you, Dan.
I was going to say, just on that, so Wendy, thank you very much indeed. We will come back onto the sort of clinical confidence and safety netting for services outside of a ward that people may or may not be aware of. And just to share a personal example, we had a patient with us. I personally spent 2 days trying to contact the haematology nurse specialist, and then went back and spoke to the patient, who said, well, why don't you talk to me? I've got their number. So I was made to feel like an absolute idiot. Yeah. So you're quite right. Dan.
Thanks, Andrew. I was going to slightly broaden your question away from just written communication and go back to communication as a whole, because I think your example there just demonstrates quite clearly how talking to the patient from the minute they get admitted to hospital about what actually is needed to get them out of hospital, and if that included talking to the haematology consultant nurse, then you'd have had that number from the minute go. And it echoes Lynn's points about that too, because if we explain to a patient and their family from the minute they get admitted to one of our units what is needed to get them home and the pros and cons of keeping them in hospital, so they can make a balanced decision about the risks of staying in or the benefits of going home, then it means that the discharge conversations you have 2-3 days down the line are a lot easier because everyone's all on the same page. And that leads to what I write in the notes. So really simple example, patient comes in with asthma. If their peak flow is over 60% of normal and they're off oxygen, they can go home. But if the nurse doesn't know that, and the nurse that I'm working with doesn't understand what I mean by 60% of normal of peak flow, then that action can never be fulfilled. So in our ward, when we're making these plans, especially if they lead to a criteria-led discharge plan, it has to be a multidisciplinary plan that all of us in the team are happy to fulfill. It can't just be a plan that only a doctor can interpret. For example, if D-dimer is normal, patient can go home. That might mean that only a doctor can actually interpret that blood result. So in terms of kind of documentation, I think it's really important that the documentation follows those 4 key sentences, those 4 key questions that the patient should have answered every time we see them on a ward round, and that purposely leads through to what our criteria-led discharge or our decision planning should be. But the amount of times I've seen those criteria-led discharge fall apart because they've been made in silos rather than talking to doctors, nurses, physios and social services all in a whole. The other thing just to comment on is, as a bit of a hint or a tip for people on the call, as part of our work with ESIS, we go around a lot of different organisations and see some fantastic work, but also some barriers to success. One of them is there's been a really sensible comment about including social services early in some of our complex cases, but some of our processes prevent that. One of the trusts we're working with recently, you could only refer to social services when the patient was medically fit for discharge, which took 2 to 3 days off people's planning for home. So back to you, Andrew.
Yes, thanks, Dan. Really appreciated that. And I think it's interesting, isn't it? Just your comments about criteria-led discharge. It feels like we made some progress that lent itself more towards that around weekends and sort of Friday handovers and sort of, but we never really took that to the next stage. And lots of places and then lots of wards will do a Friday handover, but we really haven't expanded that, and possibly that's something we should look at. And if we've got some good examples, either from the delegates on the call or that we can share, we'll put them on. Sorry, Dan.
Sorry, Andrew. I was just jumping in. Just to add to that, I think if you look at within your specialties, and obviously not everyone on the call is clinical, but if you look in your specialties and talk to the clinicians and the nurses, or the physios and the OTs on that ward about a lot of the patients, I would say about 80% of the patients that we get into respiratory, we could give you the criteria to discharge on the minute they get admitted. So if they come in with pneumonia, they go home once they're clinically improving and they're off oxygen, for example. If they've got COPD, it's when they're off nebulizers and they're off oxygen and the oxygen is within levels. So, but they're just, those plans can be done from the very early. Obviously, people are going to have kind of different routes towards that plan, but they can be done from the minute that you admit people to hospital. And it just makes the patients more aware and have a little bit more agency over their care when they know how close they are to discharge.
Thanks, Dan. And just to highlight, we're not trying to oversimplify things here, and appreciating there is complexity within this and each patient is different, but what we're trying to do with this webinar is to highlight some of the opportunities and highlight that there may be more opportunity than people think. Got a couple of things I wanted to pick up on the chat, if that's okay. Samantha from North Devon. Samantha, nice to see you back again. I know you were with us on Tuesday's webinar, and I totally agree around the link to community is often done, you know, the removal of stitches. Oh, we'll contact the discharge nurse, district nurse for that at the time the patient goes home, even they had their operation 5 days before. You know, those kind of things. You're quite right. And if you have any ideas of how to improve that, that'd be really appreciated. I'm going to bring in David, if that's okay, because lots of people bang on about TTAs, and I know, David, you have your own thoughts about this, and communication is key. Lynn has kindly highlighted in the chat that there's a new downloadable checklist, and we will add that to the chat and the handout. So Lynn, thank you very much for that. That sounds really, I haven't seen it personally, so it sounds really really good. So we'll share that for everyone. Thank you very much. So David, how can we improve things with pharmacy from our perspective?
Well, I think picking up this sort of language that Lynn was using at the start, it's about preparing beforehand and actually seeing as a failure of your processes any requirement or significant amount of requirement for dispensing a discharge. To me, that's an indication of failure. If you use patients' own medicines effectively, if you use over-labelled medicines as ward stock, if you enable nurses to be able to discharge from newly prescribed medicines at the point of discharge, you can actually get to the point where you can eliminate all sorts of delay. In Northumbria, last time we audited, 70% of our patients at the point of discharge had all the medicines in a bedside locker beside them, because the medicines are at ward level already dispensed and don't need to be dispensed by a remote pharmacy. If in your organisation you've got junior doctors writing your discharge summaries, and that's a point of delay, that is something that we did a few years back, audit, and showed that the junior doctors were, through no fault of them, I have to say, but because they were doing most of the prescribing on a ward round, the discharge summaries weren't getting processed until sometimes 5 hours after the decision was made by the consultant to discharge, because the junior doctor had to wait till the end of the round to be able to catch up with all the admin. It's all really obvious stuff, really, isn't it? You know, make use of community pharmacy for a proportion of your patients in the evening. FP10 prescriptions aren't as expensive as a patient lying in a bed and blocking up your system to really poorly people coming into your organisation. So, you know, if you can make use of community pharmacy, then that would be a good thing. Over the years, I've sometimes introduced things that haven't been terribly popular, like we've got controls on when we'll dispense compliance aids. I don't know whether people realise, but it takes about 10 times longer to dispense one person's medicines into a compliance aid than somebody who hasn't got the medicines in a compliance aid. So you can get one patient dispensed with a compliance aid, or have 10 other patients who don't discharge with the same unit of dispensing time. It's all that sort of simple stuff. And then as a maybe it's not such an easy thing, if you haven't got an electronic prescribing system that makes it all very easy to generate discharge summaries, then that's something that you really need to attend to. But all of those other things are, I think, within people's gift. It does require you to perhaps tolerate a level of medicines waste with some of the things that I've suggested, but you know, you've got to understand the value of being able to get your patients through the system, and that, to my mind, is more important than some of the cost associated with the medicines waste. So there are a few things, and actually, I know I'm bound to make a plug for pharmacy, aren't I, with being a chief pharmacist in Northumbria. But to make it all work and to get the control and for the stuff that I've described to work, then make sure you've got good pharmacy services at ward level. People will make much more of a difference to your organisations in terms of flow by the pharmacy staff. Will make a much bigger contribution at ward level than they will in the remote dispensary, where that's a failure of process. So hopefully that was a useful summary.
David, thank you. Whistle stop tour. That's not easy to say on with the headset, I can tell you. of top tips from a pharmacy perspective, and apologies because I was in contact with you at the beginning of the year around the rapid improvement guide, and that is work in progress. So watch this space. We will be putting together a rapid improvement guide around pharmacy, expanding on some of the things that David has just spoken around, and obviously compliance aid. Forgive me, it's old-fashioned term was a Dosset box. Is that right, David? So for the older of us on the call, it's an old-fashioned Dosset box. I'm always conscious of time and the richness of our discussions. I just wanted to make sure that we covered off this concept of safety netting and clinical confidence. And I've seen it today, I've seen it in my own organisation, when we have, for example, good therapy services and therapy support on the wards, there's not a lot of will to discharge into the unknown for patients who need therapy, for example. Similarly, we may see patients, or we may see clinicians keeping, or doctors keeping hold of patients to repeat blood tests because they're not sure that the patient will come back to SDEC, and we see that with 2-week wait referrals and CT scans. And I, from a personal perspective, I think that comes from a good place, if you see what I mean. I don't think that's deliberately done to cause harm or expose patients to risk, and I want to emphasize that. But I just wondered in the closing minutes whether what we can do to improve clinical confidence in services outside of the hospital. Lynn, I'm just going to come on to you firstly from a patient perspective, because you alluded to some of this before around actually a lot of the patients will have experience of what services are out there and what services they've used. And presumably it's a good idea to talk to patients around this and ask them first.
Yes, absolutely. I think I've just been thinking about some work that I was involved in a few years ago. I alluded to it earlier, whereby the local voluntary services were involved because a lot of the patients were accessing services via age concern, etc. And there were possibilities around transportation and that kind of thing, which made planning for what was going to happen to them immediately after discharge much easier, and they were actively involved in the discharge planning. So yes, I mean, perhaps sometimes it is about the patient may have the key to all this and come up with something that with the best will in the world, the carers in the hospital haven't thought of.
Thanks, Lynn, and I think it's a really good point about the third sector, and this was for Hilary, your point. This is all part of the others block in my slide. So the third sector and the befriending service and things that are offered is fantastic and often not known about at ward level from junior doctors, particularly. Wendy, any top tips from your perspective, and particularly from the community nursing perspective?
I mean, the patient, their family and their friends provide the best safety net possible. If patients have enough information and they know how to access help, then they will probably provide the very, very best net they can. And I think it's just really about talking to them about what they're worried about and allowing them to explain what help they've had before. Excuse my frog in my throat. But I think also the safety net comes from you as well. When you discharge a patient from a ward, you're not just, that's not the end of your responsibility. Your responsibility is still with just in your mindset, thinking how, have we made the right decisions? Have we had the right discussions? And there is always an opportunity in some ward areas for patients to have your number and for you to say, look, you can give us a call back if you're worried about this in the first day or so. And I think a lot of wards are trying to do that a little bit, because it probably does prevent quite a lot of reattendances as well if somebody can just phone through. And also it's others. So again, it's about the confidence in the community. And as a community nurse, I know there's great people out there and GPs as well. Next week, we're going to talk a little bit more about that. We've got a webinar next week with one of our GP colleagues. But again, if you talk to the community as much as you can, and we've had some great comments from Samantha Charlton saying community really do want to be involved in many of the patients that you're supporting on the wards, because they probably know them really well. So just pick up the phone and ask the question. and try and get in contact with somebody that you can have a conversation with. Thanks,
Lovely,
Andrew.
thank you, Wendy. Dan, I'm afraid we've run out of time, so if that's okay, we've got 2 slides just to sum up what we think are our top tips. So Crystal, if we could share the slides again, and while we're doing this, Crystal has also put in our handouts into the chat. If you're unable today, you will need to be part of the Futures platform. So if you drop an email to us, we can get you onto the Futures platform where all of the resources are available and very easy to share and download. And we've also, as I say, got these webinars on our YouTube channel, which you can use for your multidisciplinary meetings or grand rounds, those sorts of things. So to close with our top tips, really, one of the key things for me is there is not one size that fits all here. Each ward is different. You know that, I know that. The ward-based leadership culture is really important. Task allocation needs to be prioritised and spread evenly amongst the MDT. So think about competency-based working rather than professional silos. We've heard around the importance of clear documentation so it's easy, and that mitigates some of the workforce issues and challenges. We've hopefully demonstrated with the Discharge Lounge example some of the challenges that organisations face in order to make discharge easier, and with the help of Lynn, we've really, I hope, highlighted the importance of early patient involvement and empowerment, and I can't emphasize the effectiveness of that from personal experience. So just to summarize, these were our objectives, which we hope we've delivered today. We've put a link in the chat box for some feedback. We'd really value your feedback on your thoughts on this webinar, whether you'd like more, less, other topics to be covered in the future. We'll also email all the delegates a handout and a link to our Futures site. It falls on me to say thank you, and a huge personal thank you to our expert panel, so Lynn, Wendy, Dan and David, as well as to Crystal, who has been behind the scenes sorting everything out and been absolutely fantastic. But also a huge thank you for all of you for joining, many familiar faces, which is great to see. Thank you so much. Thank you for all that you're doing in these really difficult times, and we hope that today's webinar has been of help. Thank you all very much and have a good afternoon.